Welcome to the VetRay Podcast, brought to you by Sedical, the world leader in veterinary-specific X-ray technology. Visit vetray.com to find a solution for you.
Today on this episode of the podcast, we are privileged that we got to sit down and visit with Dr. Rodney Kuenzi, or as he let us call him, Dr. Rod, a second-generation veterinarian in Waukesha, Wisconsin. Dr. Rod has been involved for years in cutting-edge vital signs monitoring. Many of you may remember when pulse oximetry was introduced into the veterinary field. Kuenzi Family Pet Hospital was one of the very first clinical sites experimenting with this technology. Dr. Kuenzi has maintained vigilance in monitoring post-sedation patients in recovery and including radiology. He shares his insights with us today with our host of the podcast, Emery Shelley. Please visit our website to see a brief background on Dr. Rod and his wife, Dr. Lana. Dr. Rod, thanks again for sharing your thoughts today.
Okay, Dr. Kuenzi, I want to thank you for taking time out of your busy practice to talk with us a little bit today. What I wanted to ask you questions on was monitoring during radiology procedures, kind of the importance, what kind of monitoring would be good. I've got a few questions I wanted to ask you, but I think what we'll do is just, if you have anything that I haven't covered, ideas, concepts, thoughts, I'd love to have you share them with us. Maybe give you a few minutes to give a background. I know you're big in orthopedics, and that's one of the reasons why I thought you probably monitor post-op on the sedated patients. But if you could give us a little bit of your background. Okay. As an introduction.
I'm happy to be here. I'm going to start out with full disclosure. I'm a veterinarian in private practice. I'm not a specialist. I'm not an orthopedic surgeon. I'm not an anesthesiologist. I've been in private practice for over 30 years. I've been in veterinary OR for over 40 years. When I first started in veterinary OR, monitoring consisted of using your eyes and hands a lot more than it did using monitors. You were considered a progressive practitioner if you intubated your anesthetized patients and maybe had a repurposed human EKG that you could get a rate and rhythm on a medium-sized to large dog on. We spent a lot of time looking at our patients, monitoring capillary refill time, mucous membrane color, pupillary eye set, pupillary reflex, palpebral reflex, feeling the precordium, feeling the peripheral pulses, even anal sphincter tone. Today we got a plethora of things that we can put on animals to monitor them. But one thing that hasn't changed over time is the thing that's most important in monitoring the patient is the person that's doing the monitoring and not all the gizmos that you're hooking the animal up to. As far as monitoring in radiology, I think what we're really talking about is monitoring anesthetized patients that are not in our OR. I think veterinarians today need to be commended. By and large, they do a really good job monitoring animals in OR. They have end-tidal CO2, they have non-invasive blood pressure, they have pulse oximetry, they do continuous body temperature monitoring. They have EKGs designed for the size of the patients. We got blood pressure cuffs designed for the size of the patients and the species of the animals. But all those machines are set up in OR. They aren't necessarily portable. And a lot of times those monitoring systems don't get taken out into our prep areas or don't follow the patient from the prep area to whatever area of the hospital where we're going to do our procedures, whether it's into dentistry or whether it's into our radiology room if we're doing, pre-surgical radiographs or whatnot. So in our practice, what we try to do is to tether portable anesthetic and monitoring equipment to the technician right at the time of induction and during transport to radiology, and that whole unit stays with the technician and goes into radiology.
Now, have you seen instances, especially in a post-op situation, where maybe the animal wasn't, and this was maybe early on, wasn't monitored with a device, was just visually inspected on an anesthesia machine in radiology. And the technicians, because they're rushed, because they're not monitoring, they don't have bells and whistles going off, they maybe stress the animal a little bit during radiology. And had they monitored, or if people do monitor post-op during radiology exams, like let's say post-TPLO or procedure like that it's actually not better for the animal, obviously, but it's better for the staff too, because they're not compromising. Well, I know they're looking a little blue and things aren't quite right, but I got to get this procedure done. Mm-hmm. So they stay on task and maybe harm the animal a little bit or stress it.
I'm going to go one step farther, and I'm going to say that the veterinarian may be more likely to take their eye off the ball in radiology because there's a lot of distractions, and everybody knows that day-to-day practice, there's phone calls and staff asking you questions, and as soon as you're not in that OR, you get barraged by 1,000 different details. And I think actually our technicians or veterinary nurses or whatever term that your state or your practice uses for that are way better at staying on task sometimes in the non-surgical theater than the veterinarian is, but certainly having monitoring in radiology is an asset, and knowing what heart rates are, knowing how well our patients are oxygenated with pulse oximetry, being able to see the EKG rate and rhythm, being able to see the pulse ox, pulse pleth readout, knowing what the perfusion index is, knowing the quality of the peripheral perfusion is really benefit and an asset to our patient care. And we even can step in with portable entitled CO2 machines that can be put into our units now that are handheld, that can get an idea of how well we're actually ventilating metabolically with that patient. That can be in our pockets. So everything's way more portable than it used to be.
Yeah, so the new small devices will really help that transition.
Yep.
How many times, or is obviously it's beneficial if you can leave an endotracheal tube in post-op, go to radiology, let's say you're doing abdominal surgery or thoracic surgery, so you can get some good inspiratory films. But again, to get good quality inspiratory films, you need the anesthesia machine, you need somebody bagging the animal, and then again, monitoring. So monitoring, pulse oximetry, EKG, be the basics that you could get by with on light anesthesia? In
our practice, when we're moving animals from place to place in our practice and into our diagnostic rooms, into our radiology, our minimal database and technology is going to be pulse oximetry and ECG. There's a lot of other things that may be added, and that's going to be up to the individual doctor and technician on that case. And they have the options to add those, but that's definitely the minimal database, and all that information is being recorded and placed in the record. For medical legal reasons these days, those values are started at induction and during surgical prep, kept track of during transport. If we're going to radiology, they're recorded at least every 5 minutes when we're in radiology, and during transport before we go into the surgery, and then all through the surgery. And they're continued to be monitored in the OR cage, and even after extubation until we're sternal. And depending on how critical or, how mobile that patient may be or how sedated it may be, a monitor may be left on the animal for minutes to hours post-surgically to continue that. And the portable units that we have nowadays, we can even Bluetooth the signal to a technician's cell phone or tablets, and they can even step away from the case if it's not mission critical, that they be right there, and we can be monitoring signs while we're doing some other minor task or be in laboratory or whatnot. So, and
that'd be a perfect scenario of the veterinarian seeing the display while the technicians are behind closed doors in radiology where it's dark and,
Correct.
no one else can really keep an eye on that animal. Their mission critical is to get those images. So they're focusing on positioning and taking images, not really looking at a monitor, not having time to look at a monitor, but the veterinarian could be outside or, like you say, taking a phone call, doing other things and watching his phone.
Yep.
That's a great idea.
Yep. And everybody today has got their computer in their pocket, and there's a million apps on there, and we got an app to monitor our patient. It's great.
That's great.
Yep.
Now, we're in Wisconsin, and we don't do a lot of sedation, but some states like New York and other practice, it's practice by practice. A lot of people do mild or light sedation to get good images. Again, monitoring during light sedation, do you find that valuable? Have you had a situation where you thought things were going along good and they started to take a turn where having monitoring, you might be able to catch that a little bit before?
Yeah, I definitely have given pre-meds and started our EKGs before inductions and during what we considered slight or mild or moderate sedation, and picked up arrhythmias that we didn't know existed, and we're glad to know were there before we went to a total anesthesia. Yep.
It's kind of like digital X-ray. Is nowadays you find things that you weren't looking for just because that information's there.
Yeah, we find ourselves using our monitors as pre-surgical screens almost in inductions. Yeah.
So pretty much you would advocate anytime any patient is anesthetized, even if it's light anesthesia and they're going in for radiology exams, it'd be a great idea to at least put a pulse oximeter on?
Yeah, pulse oximeters and EKGs are easy to use, and they're quite portable these days. So that's the advantages of them. Disadvantages of them is they may not catch things as quickly as what Entitle CO2 might or whatnot. But portability and ease of use is somewhat paramount in the day-to-day practice to speed things along here. So,
Well, do you think if a patient was monitored in radiology, would it maybe increase the radiology time or actually decrease because they would be able to work through the procedures and know that everything's okay and not keep checking the tongue or other?
Yeah. Well, there is something somewhat soothing once you're used to it, hearing the constant beep of the constant tone of the pulse oximeter, and at a certain tone that is between 98 and 100% oxygenated blood. And when that tone changes, to be looking at the patient. And when you got an animal anesthetized and you don't have that on there, you almost feel naked not having it on. And I know all my staff do not want to do an anesthetic without having a monitor on the patient here. It's kind of a safety blanket here these days. So, and every one of my technicians has a portable monitor on their person if they're on surgical duties, and a lot of them carry it just on ICU to do vital sign monitoring and checking TPRs and whatnot during the day too.
What about trauma when you get hit by a car or something like that? One of the immediate things is to try and get x-rays, right, to ascertain whether you've got broken bones or what's going on. Monitoring there is critical.
Absolutely. If you got bruised heart muscle, obviously, if you're throwing arrhythmias, the premature ventricular contractions right away on a thoracic trauma case isn't a good way to start out. Or if we're not perfusing well, those aren't good. And watching the trends as the patient progresses, knowing where you started, and if you're going south quick or getting better is good information to have here.
So virtually any trauma need to put a monitor on during radiology, just because of the time the animal's on the table, and again, maybe not being observed, focused on as much as you'd like, because they're focusing on positioning and getting the image. That's nice to have that third sense that you're going on. Yep.
In radiology and ICU and other diagnostic areas in the hospital. Yep. And the more mobile that unit is, And the more familiar your staff is with using it, the better.
Well, yeah, I can see where having a monitor on the patient lets them maybe take the time they need to position correctly, and they're not hurrying through it. So that hopefully the result is a better image.
Image and less retakes. Yep.
Yep. Excellent.
Yep.
One of the other areas that I'd like to talk to you about is OFA. I know that you do a lot of OFA and pen hip, and I'm just wondering what kind of awake sedation do you do with OFAs? Is there any pros and cons to doing sedated versus awake OFA?
I think this has been a controversy for the whole time I've been in practice. OFA accepts x-rays on awake dogs, and we're talking about hip x-rays. They accept them on sedated dogs, and they accept them on anesthetized dogs, and you just have to indicate what you used on the submission form. And for 30 years, I have offered the service of doing OFA hip x-rays on awake dogs if we can manage it, if our staff can restrain the dog well enough to get a symmetrical hip x-ray and be out of the x-ray beam off the table with that patient. We do have foam positioners, cradles that allow us to hang on to the front and rear paws so that we're substantially out of the beam and away from much scatter. And we, of course, use all the lead apron and thyroid shields and glasses and whatnot. Certainly the clients, a lot of clients like that service, to not have to anesthetize their dog for hip x-rays.
So they prefer that over even mild sedation.
I have clients that drive a substantial distance for that service. We certainly do anesthetize some animals. I personally have found it a lot more difficult to be able to get a decent flexed elbow OFA view on an awake animal and to keep my parts out of the beam. And we don't do OFA elbow x-rays without sedation, so we do use chemical restraint for that. But when you can imagine trying to hold the dog down laterally, bend the elbow, and try to get a decent x-ray, it's a lot more difficult than stretching the dog out on a foam V cradle and pulling his hip straight and quick taking the shot here. Digital x-rays have made that a lot easier to do. You don't have to wait 4 minutes to see if you got the hip positioning right, and then if you didn't, throw them back down in the foam cradle and retake it. You can just roll it one way or the other and take another picture real quick if you don't have it right the first time. So the digital x-rays have really improved the OFA awake.
So your throughput time is much improved with digital.
A lot.
Great. Are there any other procedures where digital you think has improved, pre-op exams, post-op exams?
I just think we're way more likely to take the x-rays we should, and I say that as a busy practitioner. When you can take them and see those images 3 seconds later, as opposed to wait 3 or 4 minutes to get through the developer. And I go back to dunk tanks here, so when it took 15 minutes to be able to see the image, I know we didn't take as many x-rays. So having the image right away, we take a lot more 3-position chest x-rays. I'm going to read it and know if I got the right positioning right away. I think our contrast studies, where we take a lot more films, take a lot more images, I guess I should say, with our contrast study. And we're take the films, or take the images that we should take, and we're a lot more likely to do so because it's just an easier operation.
So you're more prone to do barium studies now than with film and other contrast bladder studies? Yeah,
I like to say that we would always have done what's necessary, and I just think that our life's a lot easier with digital x-ray than it used to be.
Now with digital and OFA, I have to backtrack a little bit. They take just images on CDs. They're not able to do DICOM transfer or receive DICOM images right now, right?
Okay, yeah. So OFA wants us to download our JPEG images onto a thumb drive and load it onto a Microsoft platform on a separate computer and send in the images without our reader, so that so they can upload the images only onto their reader. And that's currently how they want us to handle the submission.
That's a few extra steps.
It is, and PinHip is way past that now. They will take it directly and actually require it directly. So you can't even, if you had films, you can't even mail them directly anymore if you were still doing the film.
So with PinHip, now the animal has to be sedated with PinHip, correct?
Has to be heavily sedated or anesthetized with PinHip, so you can actually have the laxity in the joint to measure what the distraction index is on that patient.
Is it the breeder preference or the owner preference, whether you go OFA or PinHip?
It is the individual preference. I think there's enough work done to show that the PinHip values are a lot more indicative of genetic transfer of how well the hips are formed than OFA is. So, and to state it another way, it is a dynamic measure of how lax the hips are, and the lower the distraction index, the tighter the dog's hips are. Actually, it puts the actual numeric value on how tight the hips are, and every breed has its own average number. Okay. It also, by definition, with PinHip, kind of fails half of the submissions because half of them are going to be above average and half of them are below average, where OFA has excellent, good, fair, borderline, and then all the levels of dysplasia, and more dogs, and it's a subjective way of reading it, and more dogs are going to quote unquote pass OFA.
So it's more of a breeder preference as to how they get the animal scored, which direction they go, OFA or PinHip.
And PinHip is more time consuming, more expensive to do
because of the sedation and the increased time.
And it takes multiple views. It's just more labor intensive to obtain the study. I guess both of them are fairly closely held processes, so I guess there's a little bit of a monopoly on both sides of that. So,
one question I wanted to ask you was, if you do monitor a patient during radiology exams, do you charge for it, or are you able to charge extra for it, or is it just more of a clinician confidence?
I think that's a question that's answered by every individual practice on how exactly they charge for anesthetic monitoring. And I'm going to answer that in the realms of my own practice when I answer it. We charge by the half-hour unit of anesthetic monitoring. And every time we do an anesthesia, we charge for at least a half hour of anesthetic monitoring.
And that would extend into radiology too.
Would, and it's a set fee, and that doctor and that certified veterinary technician chooses the modalities that they wish to use to monitor that patient. So they may choose only to do ECG and pulse oximetry. They may choose to do EKG, pulse oximetry, and tidal CO2 continuous, blood pressure continuous, body temperature, apnea monitoring, tidal volume monitoring, whatever, anesthetic gas monitoring. It's all the same fee. You're getting charged for a half an hour unit of monitoring. From myself personally, I don't want any excuses for, well, if I would only done in tidal CO2, let's say I might have had a better outcome on that anesthesia. There's no excuses for not using the modality that you think you need on the case. So do safe anesthesia, use everything you need. You are in control of your anesthesia, and do it the right way.
And monitoring is a help to everybody.
It is. It's and it improves your safety of your patient and your patient care, and if you save one patient, whatever you have spent on your monitoring system paid for itself right there.
That sounds great.
Yeah.
One of the other areas I'd like to ask you about, again, since you do a lot of surgery with the advent of wireless digital detectors, that opens up a lot of flexibility. And I know you have kind of an interest in being able to take images interoperatively. Is that something that you think really will help kind of the future of surgery, radiology, being more flexible with a mobile X-ray unit that can go into surgery?
Yeah, I've often been in the middle of an orthopedic procedure and said, I wish I had a C-arm because I wish I knew where the end of this pin was or where the end of the screw was, or if I had the fragments lined up like I think I do in all this soft tissue.
So fluoroscopy would help too.
It would, and this day static X-ray would be great. Instead of having to take down your whole sterile field, move the animal all the way into your X-ray room and take the picture and say, I need to advance that pen a little bit, or, that fragment isn't where I thought it was, and then going all the way back into your OR and putting down a new sterile field and going back in and making the adjustments and closing the wound a second time and whatnot. So if we had a mobile X-ray unit in our practice, I think that would be an excellent way of using it, is being able to roll it into my OR and capture an image on our surgical patient on the surgical table. Likewise, critical patients in the work area, instead of having to move that animal into the radiology room, if we were able to take a mobile unit right to where we were working on a traumatized patient on our island area and in our work area, I can see advantages of taking trauma films right there and being able to see what's going on as well. I think the old way of designing veterinary practices with a completely separate X-ray room, if you will, I would rethink that today if I was designing a clinic. I think there's better way. Just the technology is making things better, and mobile units are being used a lot more in human medicine. I think veterinarians need to take a long, hard look at that and use that 10 by 14 room that designated completely for X-rays. You could put that to better use as an exam room or a laboratory or something else, and take your machine to where it's needed. I
think that's a great idea, especially in some of the more high density populated areas where real estate's really expensive and they're trying to minimize space. And radiology is one of the rooms that I've seen oftentimes get squeezed down to a point where it really isn't much bigger than the X-ray table. And again, that limits the flexibility and usability of radiology. But I'm intrigued with that whole mobile concept, because with the wireless panels, you have the same flexibility that you had with a film cassette. But like you say, you get the image in 3 seconds. That gives you a great opportunity to work in that trauma environment where the trauma tools are right there, anesthesia where the anesthesia tools are right there, so that you have the ability to actually manage the case so much better.
Yeah, it's actually a paradigm shift in how we're thinking about it. It's taking the machine to the patient and not the patient to the machine. That goes all the way back to the World War II machines that basically threw out the X-rays in a sphere all the way around it and weren't collimated, and you had to have lead line rooms to even use it, and everybody had to leave the room, or at least you were supposed to. With these new digital units that are on wheels, the human physicians are wanting their patients X-rayed at bedside. They're wanting them X-rayed on the exam tables, and the human RTs are pushing those machines up and down the hall and into elevators and taking them all over the hospital. And I think that's really kind of the new wave of what we maybe should be looking at in our practices. So,
well, like you mentioned on the human side too, I know in a lot of the MASH units, the forward deploy units, portable is the only way. And that I'm very intrigued with, again, that paradigm shift and what it could do to veterinary medicine and convenience, time.
And the images you get out of portable units anymore are just a whole different ballpark than what they used to be, too. Those old heavy equine units that just kind of blew through everything back in the day, or, with wet films are a thing of a past. So.
Yeah, some of the mobile units. I know your son is ex-Navy radiology tech, and those units have the same power, if not even more, than the conventional table units. Yep. So quality of image, it's the same no matter what the environment is.
Yep.
That'd be great. Well, thank you, Dr. Kuenzi, for taking time out of your practice to spend a few minutes and give us some of your thoughts and ideas. Much appreciated. Again, one of the things I know is that you're actually second-generation veterinarian, right?
That's correct. That's why I've been at it so long. My dad wanted to make sure that I had things to do since I was 6 years old. So I've been doing this for 51 years in some aspect of whatever. But it's been a pleasure talking with you today, and be happy to do it again sometime.
All right. Thanks again. Appreciate it.